Hello, my name is Gracia Sanchez and I'm going to talk about non-alcoholic fatty liver and fibrosis. First, definition. Non-alcoholic fatty liver disease is a complex condition involving the progression from simple steatosis to inflammation and then to severe fibrosis and hepatocellular carcinoma. Some of the symptoms of this disease are a dull or aching pain in the top right of the tummy, extreme tiredness, unexplained weight loss, and weakness. On the other hand, notch promotes enhanced tumor malignancy by contributing to development cancer stem cells and resistance to chemotherapy. Activation of the notch protein in the hepatocytes increase the synthesis of intracellular triglycerides by stabilizing another protein.
Non alcoholic fatty liver disease is actually a spectrum of disease, going from least to most severe, steatosis, steatohepatitis, fibrosis, and finally cirrhosis. Non alcoholic fatty liver disease results from fat deposition in the liver, which is unrelated to alcohol or viral causes. Typically, it affects individuals with metabolic syndrome, which includes a combination of three of the five following diagnoses: obesity, hypertension, diabetes, hypertriglyceridemia, and hyperlipidemia. Given how common metabolic syndromes become, it's not surprising that the rate of non alcoholic fatty liver disease has also increased dramatically. It's a massive problem, growing in lockstep with expanding waistlines, affecting about 3/4 of all obese individuals, including many children. Although the exact mechanism of non alcoholic fatty liver disease isn't clear, insulin resistance seems to play an important role. Over time, insulin receptors on various tissues, including the liver, become less responsive to insulin, and as a result, the liver goes into a mode where it increases fat storage and decreases fatty acid oxidation. That means decreased secretion of lipids into the bloodstream, in the form of lipoproteins, and increased synthesis and uptake of free fatty acids from the blood, a process called steatosis. Steatosis causes fat droplets to form within hepatocytes, some of which become large enough to cause the hepatocytes to swell up with fat and push the nuclei to the edge of the cell. You can even see this on a histopathology slide of the liver. All these white circles are large deposits of fat. Zooming out and looking at the liver, you see widespread steatosis, which makes the liver appear large, soft, yellow, and greasy. Over time, that fat in the hepatocytes becomes vulnerable to degradation. Unsaturated fatty acids, or fatty acids that have at least one double bond in their carbon chain, have hydrogen atoms that are especially vulnerable to initiators, like reactive oxygen species, like the hydroxyl radical, which has an unpaired electron. In this example, the hydroxyl radical pairs with the vulnerable lipid hydrogen to make water and a fatty acid radical. The fatty acid radical is unstable and reacts with non-radicals, including molecular oxygen and undamaged fatty acids. This goes on until one radical species reacts with another radical species, which terminates the reaction. This process damages lipid membranes, leading to things like mitochondrial dysfunction and eventually cell death.
Application in medicine. SPP1 produces an elevated secretion of fibrogenic factor OPM. SOX9 is the transcriptional mediator of Notch-induced SPP1 expression in hepatocytes. Notch inhibitors are in clinical trials for cancer. It's the most commonly studied of these gamma secretase inhibitors, or GSIs, that blocks endogenous production of NICD. In the experiments, GSI are vehicle once daily for 1 week, initiating treatment after nearly 4 months of NASH diet. Acute GSI treatment did not alter body weight, adiposity of liver, inflammation. In 1 week of GSI exposure is insufficient to reverse liver fibrosis. But they developed a liver-selective gamma secretase antagonist to bypass intestinal distribution called nicastrin antisense oligonucleotide, or NCST-ASO.
Cell death generates inflammation, and together the process of steatosis and inflammation is referred to as steatohepatitis. In the absence of alcohol, this is called non-alcoholic steatohepatitis, or NASH. In addition to bloating and dying hepatocytes, there might be additional histopathologic changes like the presence of Mallory-Denk bodies, which are tangles of intermediate filaments that can be seen in the cytoplasm of hepatocytes. The mechanism, though, for how these form is still unclear. Hepatocyte damage also attracts neutrophils into the liver tissues. And finally, chronic steatohepatitis can cause liver stellate cells to lay down fibrotic tissue, causing the disease to be classified as fibrosis. As the process of fibrosis continues, the overall architecture of the liver changes, to the point where the disease is classified as cirrhosis. Even at the advanced stage of steatohepatitis, an individual might have no symptoms. And when there are symptoms, they're often vague, like fatigue or malaise. Once there's significant liver damage, though, there can be hepatomegaly, or enlargement of the liver, pain in the right upper quadrant of the abdomen, jaundice, and even an accumulation of fluid in the peritoneal cavity, called ascites. Because hepatocytes are being destroyed, there can be an increase in liver enzymes like aspartate transaminase, or AST, and to a greater extent, alanine transaminase, or ALT. Classically, progression of steatosis to steatohepatitis and then to cirrhosis causes an increase in the ALT and sometimes AST. In contrast, alcoholic liver injury generally causes a big increase in AST and a more modest increase in ALT, giving an AST to ALT ratio generally greater than 2. If non-alcoholic fatty liver disease is suspected, a diagnosis can be made with imaging studies like ultrasound, a CT scan, or an MRI to look for fatty infiltrates. In addition, a biopsy of the liver can be done to confirm the diagnosis and assess the severity of the disease. Generally speaking, a liver with more than 5% fat content is considered abnormal. Steatosis, and to a lesser degree steatohepatitis, is generally reversible by addressing the underlying cause, although that's generally not the case once fibrosis and cirrhosis is set in. The goal is to reverse the factors that contribute to insulin resistance, mainly through a healthy diet and an active lifestyle, as well as medications to control blood glucose levels if needed. Alright, as a quick recap, non-alcoholic fatty liver disease happens when fat is deposited in the liver, a process called steatosis. Inflammation from steatosis can lead to steatohepatitis, and chronic steatohepatitis can lead to fibrosis, and ultimately to cirrhosis. This spectrum of disease is thought to be caused by insulin resistance, and depending on the stage of the disease, it can be reversed with careful attention to diet and exercise, as well as with medications to help control blood glucose levels.
Pros and cons. Pros: reduce the incidence and severity of liver steatosis and fibrosis. NCSTA did not affect liver tunnel staining, serum transaminases, or liver inflammation, but effectively reduced expression of HSC markers and collagen depositations. NCSTA lowered body weight and adiposity reduced liver NCST, notch activity, and PP1 expression. Cons: intestinal toxicity and notch signaling promotes enhanced tumor malignancy by contributing to development of cancer, stem cells, and resistance to chemotherapy.
Collectively is an umbrella term known as non-alcoholic fatty liver disease. And this can include plain fat in the liver, shown here, or progression to an inflammatory fibrotic condition known as steatohepatitis or NASH. NASH, over time, in many cases, will progress to cirrhosis. And of considerable concern once cirrhosis is developed is the heightened risk of hepatocellular carcinoma or primary liver cancer. Most clinical trials, virtually all clinical trials that are addressing NASH, focus on the steatohepatitis stage and not on steatosis alone. One other critical point to emphasize is that Unlike other diseases, there's a reasonably high fraction of patients who develop hepatocellular carcinoma with NASH who are not yet cirrhotic, far higher than for, let's say, hepatitis C. And so we need to raise our level of vigilance for emerging hepatocellular carcinoma in any patient with NASH who has moderate to more advanced fibrosis even before they're cirrhotic. This map depicts the obesity trends in the United States, which is probably familiar to many of your audience, showing the intense prevalence of obesity. And associated with that, as I mentioned, is a rising prevalence of fatty liver disease, which is projected to rise exponentially over the next few decades. Currently, it's estimated that 65 million Americans already have one form of fatty liver disease or another that will rise in the next 15 years or so to 100 million. Of this 65 million, at least 16.5 million now have NASH. This is the condition which really merits attention and possibly treatment or enrollment in clinical trials, and this will rise to 27 million by 2030. And I also emphasize the importance of vigilance for hepatocellular carcinoma, or HCC, which is projected to rise precipitously as well over the next decade and a half. I alluded to the fact that whereas NAFLD is a condition that of itself is not necessarily associated with progression to cirrhosis as shown here, whereas NASH, meaning once there's an inflammatory or fibrotic state, the progression rate to cirrhosis, while not clearly clarified yet, is certainly much faster than if there is fat alone. So once the diagnosis of NASH is made, especially if there's any element of scarring, this really connotes a potentially high risk of progression and the need for monitoring and possible treatment as they emerge. Of all the different components of the histology of NASH, which include ballooning or a specialized kind of cell death of hepatocytes, lobular inflammation and cell injury, as well as fat, the most important predictor of outcomes is neither of those, but rather the fibrosis stage. What you're looking at here is a paper from several years ago by Zoberianassi and his colleagues, Zach Goodman and others, that looked at the natural history or outcomes of patients who were diagnosed with NAFLD over a 300-month period based on their presenting stage of fibrosis. And what's clear from the solid line that travels down the chart is patients who began this observation period with a NAFLD activity score fibrosis stage of 4, which is cirrhosis, had a much poorer outcome. And so increasingly clinical trials are focusing directly or indirectly on the ability of a drug to ultimately reduce the progression of scar or fibrosis and to prevent the development of cirrhosis.
Issue applied in Ecuador. The main cause for a person to develop liver fibrosis and linked to several factors. One of them, considered the main one in Ecuador, is fatty liver associated with the poor diet of Ecuadorians. In the country, 5 out of every 100 people with fatty liver develop cirrhosis, which is the final stage of liver fibrosis. This means that not all the people who have this will end up with the cirrhosis, emphasized Dr. Gonzalo Benalcázar, specialist in hepatology and liver transplantation. Another of the main causes is chronic liver infection caused by hepatitis C or hepatitis B viruses, which due to their complex natural the liver more prone to accumulate fibrosis. According to the U.S. Health, in this country, CH is the first factor associated with cirrhosis in Ecuador. 5 out of 100 people with fatty liver develop cirrhosis. Liver fibrosis in its the final phase, or F4. Conclusion. Non-alcoholic fatty liver disease is a very common disorder and refers to a group of conditions where there is accumulation of excess fat in the liver of people who drink little or no alcohol. The most common form of NAFLD is a non-serious condition called fatty liver. In fatty liver, fat accumulates in the liver cells. Although having fat in the liver is not normal by itself, it probably does not damage the liver. Notch inhibitors are in clinical trials for cancer. It's the most commonly studied of these are gamma secretase inhibitors potentially toxic in a longer treatment. And that's the reason to develop another thing to that is nicastrin antisense oligonucleotide or NCST ASO. That is a liver-selective gamma secretase antagonist to bypass intestinal distribution. What can avoid toxicity? Thank you.